Hi, good day. Assalamualaikum warahmatullahi wabarakatuh, and a very good day to all of you out there. My name is Amiruddin bin Jinli. I am a student of Medical and Health Sciences, Open University Malaysia, Petaling Jaya Learning Center, and today I would like to do my case presentations on my case study. It's all about the management and care of patients having hypovolemic shock in pre-hospital care setting. Prior to my posting for subject NBCP2424, pre-hospital care and ambulance services clinical practice, and I've been posted in pre-hospital care unit in emergency and trauma department hospital Tuanku Jaafar, Seremban, Negeri Sembilan Darul Khusus. Assistant medical officer plays vital roles in pre-hospital care in Malaysia. For example, the assistant medical officer involved in Medical Emergency Coordinate Center or MECC as call taker and also call dispatcher. This assistant medical officer also involved in responding any cases, whereas trauma cases or medical cases or even maternity cases. Therefore, as assistant medical officer, they have to be good in assessing patients and also resuscitating patients in pre-hospital care for the better delivery and also better outcomes of the patients. According to Figure 1 by Sika and Margolis in 2005 shows that a continuum of care. As pre-hospital care services are part of continuum care, public or bystander as first responder in providing necessary care and recognitions of notifications emergency conditions up to rehabilitation. In Malaysia, the process of responding any cases starts from the bystander to the call centers that are located in Kuala Lumpur, Melaka, and Kuching, Sarawak, and connected to any medical emergency coordinate center, MECC, and General State Hospital in Malaysia. This call center managed by the assistant medical officer as call taker and call dispatcher. Not only that, assistant medical officer also involved in responding cases. Therefore, the roles of assistant medical officer and pre-hospital care in Malaysia is very crucial. As first responder, assistant medical officer needs to fulfill themselves with adequate knowledge, for example, the knowledge of basic life support, trauma life support, and also pre-hospital care to help them deliver best treatment and management to patients. Whenever assistant medical officer responding any cases, emergency cases, it is divided into three main cases, whereas medical emergency, trauma cases, and maternity cases. In Malaysia, trauma as second cause of mortality and road injury leading the chart with 35 to 30 deaths per 100,000 population. Therefore, assistant medical officer as first responder need to be skillful and able to manage patient accordingly, especially related to trauma patients. According to trimodal distributions of trauma death, the first peak, approximately about 50%, is within minutes of the injury, such as laceration wound of a brain, brainstem, aorta, heart, and heart. Second peak of death, approximately about 30%, occurs within a few hours to 48 hours, such as EDH, SDH, pneumothorax, pelvic fracture, and long bone fracture, and abdominal injury. Last but not least, third peak of death occurred within 1 to 4 weeks. Approximately about 15% of death represent those patients who die from the complications of their injury or treatment. Therefore, according to the trimodal distribution of death, the most common cause of death is injury leads to bleeding. As assistant medical officer act as a first responder, therefore they should be able to do related maneuver that might help to stop or reduce bleeding among patients to avoid further effect of bleeding, which is hypovolemic shock. According to Marcin and Nall in 2018, explained that hypovolemic shock is a life-threatening condition that results whenever body's blood or fluid supply lost more than 20% or 1/5. In this severe fluid loss, it is impossible for the heart to pump a sufficient amount of blood to our body. These conditions also lead to organ failure. Figure 3 shows the signs and symptoms of hemorrhage by class. According to the Advanced Trauma Life Support 10th edition, the management of hypovolemic shock in trauma case includes early use of blood product, management of coagulopathy, and use of tranexamic acid. Early resuscitation with blood and blood product on patients with evidence of class 3 and 4 hypovolemic shock should be considered. Early administrations of blood product at low ratio of packed red blood cell to plasma and platelets can prevent the development of coagulopathy and thrombocytopenia. Uncontrolled blood loss can have occurred in patients taking antiplatelet and anticoagulant medication. Therefore, healthcare providers should obtain medication lists as soon as possible and administer reversal accordingly. Medical officer should consider to administering platelet transfusion even with normal platelet count in this patient. According to previous study from European and American military demonstrates that improved survival when tranexamic acid is administered over 10 minutes within 3 hours of injury followed by infusion tranexamic acid 1 gram over 8 hours in hospital. Assistant medical officer also needs to be careful in detecting the source of bleeding. This is because causes of bleeding is not only can see over outer of human body. It is also occurred inside patient's body. For example, early detections of cardiac tamponade, pelvic fracture, and long bone fracture can avoid further bleeding that might cause hypovolemic shock on trauma patient. Assistant medical officer need to be good in applying related device such as pelvic binder and any traction device for femur fracture to stabilize the fracture site and to avoid further injury. In this case study, it will discuss more about management and care on patients with hypovolemic shock, specifically in pre-hospital care setting. By using specific precautions, including initial scene assessment, such as evaluate danger and ensure the scene safety, asking for patient response, airway management, and cervical protection, breathing assessment, circulation management, including assessing patient's vital sign and sign of shock, assessment on patient neurological status, and last but not least, complete assessment on patient spine at the end of primary survey. Information in patient's demographic data and general health history. This patient is 16 years old Malay gentleman working as a student. The pre-hospital response detailed this case call taking by PPPS and dispatched by PPPA. Time motion, the call received by 6:25 p.m., en route at 6:30 p.m., at scene at 6:45 p.m., and at patient at 6:50 p.m. Transporting patient at 7:10 p.m. and arrived at the hospital at 7:20 p.m. The chief complaint of these patients is alleged MVA, motorbike skidded, sustained multiple abrasion wound over body. The history of present illness, these patients have been motorbike skidded during went back from home from school, and he's tried to avoid another car from front. Patients not wearing helmet and fall at left sides of road. General conditions, and we're doing the primary survey, assessing the danger of scene safety. The scene is safe, involving trauma patients and 1 patient involved. There is no backup needs. Assessing patient response, patient alert and conscious. Assessing patient airway, airway is patent, able to talk. There is no vomiting and no nausea. There is no loss of consciousness. However, patient unable to recall what was happened to him. Assessing patient breathing, we using the IPPA mnemonic. On inspection, there is no trachea deviation, only having a multiple abrasion wound at chest region. There is no paradoxical movement. There is no obvious open wound seen. Adequate chest expansion. On palpation examinations, there is no tracheal deviation. However, the chest spring or touch is positive. There is no subcutaneous emphysema, no crepitus. On percussions, patient having a resonance sound heard. There is no, on auscultations, there's a normal breathing sound, adequate, and no muffled heart sound heard at the apex. Assessing patient circulation. The CRT delayed. The skin color is still pink, cold peripheries, pulse palpable, and tachycardia rate 110 per minute pulse rate. There is regular and strong pulse volume. However, patient having active bleeding from left distal upper limb, and we suspect this patient having left fracture radius ulna. The direct compressions applied and bandaging, the upper limb splinting also applied. We also suspecting this patient having left femur fracture. Therefore, the health traction splint applied to patient. Assessing patient neurological status, patient GCS is 14/15. Patient only open his eyes whenever we call his name, and the verbal is 5 and his motor is 6. So 14/15. And the pupil still reactive to light. We're doing the exposure. There is no sign of spinal shock, no abnormalities from back. Anal tone not performed. The vital signs obtained from these patients: blood pressure was 101/52, the temperature was 36.9, the glucometer is 6.3 millimole per liter, the heart rate is 113, the pain score is 9/10, saturation of oxygen is 99% under high flow mask, respiration rate at 20 per minute, the GCS as I mentioned earlier is 14/15. The secondary survey, we're using the sample mnemonic. The sign and symptom: patient having deformities and open wound 3 cm plus times 2 cm over left distal upper limb, to rule out open radius ulnar fracture, and deformity over left femur region to rule out left femur closed fracture. Patient having tachycardia, borderline low blood pressure, and delayed CRT. We suspect patient having hypovolemic. The patients having no allergy history to medication or food. Patient in good health, not taking any medications previously or before even occurred. The past medical history: patient having no medical illness, patient having lunch before scene happened, and exact happened patient having MVA motorbike. As I mentioned earlier, there's no medical illness. Patients also have a no surgical history. According to patient's mother, he was second child of 4 siblings, and the patient was normal at home, no suicide intentions during. The documentations of assessment on assessment findings. We assess patient's head and neck. On inspections, there is abrasion wound over face region, no obvious laceration wound, no hematoma, no burn scars, no obvious deformity seen, no punctured wound. We also doing the palpations of the trachea. There is trachea is central, no carapatus, no subcutaneous emphysema, and also there is no increase of measurement GVP. Sign anterior and posterior. On inspections, we inspect the upper limb, open wound and deformity of a distal left wrist with multiple abrasion wound, actively bleed, and also close deformity of a 2/3 femur region with multiple abrasion wound. On palpation, upper limb, tender on palpation of distal left wrist, otherwise no obvious deformity felt from other parts, and lower limb tender on the palpations 2/3 femur region, otherwise no obvious deformity felt from other parts. So this is the human figure that we see in the multiple abrasion wound of a facial, open wound 3 cm times 2 cm, and deformity distal left hand and abrasion wound, and also cause deformity of a 2/3 left femur region with abrasion. So the chest and lung inspections: trachea was central, no chest wound, no paralytical movement, and good chest expansions. On palpations, no crepitus, no subcutaneous emphysema. However, the chest ring is positive. Sorry. The percussions: no hyperresonance sounds, no dullness sound, equal A entry. And the cardiovascular system: overall patient's pink, however having delayed CRT more than 2 seconds. Auscultations: double rhythm, no murmur, no muffled heart sound. Palpations: pulse palpable, a good pulse rate, and good pulse volume. The patient having tachycardia is 110 per minute. The elementary inspections, no obvious abrasion wound and laceration wound seen, palpation soft, not tender, and also having a normal in percussions, and normal bowel sound and measurement of liver is not large. And ophthalmology, the inspections, no laceration wound, abrasion wound over bilateral eyes, and also having no nasal bleeding and no deformity seen. And inspections in ear, there is no ear bleeding, no laceration wound, and abrasion wound from the bilateral ears, and also inspecting patient's throat, there is not injecting and not bleeding. And central nervous system, as I mentioned earlier, the mental status was 14/15 GCS. Coordination and gait test, unable to assess gait test due to the patient's having deformity of a left femur region. Patient able to mention date, time, and name. However, patient unable to recall what is happened during X. And inspections of the genitalia, there is no bleeding from the genital. The dermatom test, pinprick test, normal, and light touch test is also normal. And motor tests, there is all normal in right side power, sensation, and reflexes. However, unable to assess the power and reflexes over the left upper limb and lower limb due to fracture that we mentioned earlier. So these patients having alleged MVA, motorbike skidded, sustained closed left mid-shaft femur fracture, open fracture of a distal end of left radius ulna, abrasion wound over facial region, and also having hypovolemic shock. Discussions on medical and surgical management of the patient. So we're doing the assessing scene, patient and self-safety. Informed and medical base, this is from a patient involving one patient, so there's no need of backup. No hazard at patient, and we're wearing the PPE such as disposable face mask, apron, and disposable gloves. And we're performing the primary survey on this patient. We're assessing airway patency. Patients able to talk, hence the airway was patent. Cervical collar put on these patients due to these patients might have retrograde amnesia, and GCS a little bit low at 14/15. Assessing breathing adequacy and deformity, patient able to breathing spontaneously, no accessory muscle used during inhaling and exhaling. Performing chest palpations to determine any life-threatening injury, and we found that chest spring is positive. However, there is no sign of pneumothorax, attention pneumothorax. There is no sign of open pneumothorax and cardiac tamponade. And we're also doing the assessing patient's perfusions. The capillary refill times is delayed. Minimal sign of cyanosis, tachycardia, pulse at rate at 110 per minute. There is sign of the shock. Deformity on distal and left wrist with open wound 3 cm times 2 cm actively bleeding. Performing direct compressions and bandaging. Put on upper limb splinting on these patients. The deformity of a 2/3 left femur region. There is no open wound seen. Patient put on hair extraction splint. We are inserting 2 large ball intravenous cannula and run 2 pint warmer saline in view of tachycardia. Patients also give 1 gram of tranexamic acid in 100 ml normal saline and run in 10 minutes in view of query blood loss on this patient and in shock. Assessing patient's serological status, the GCS was 14/15 E3V5M6, purple reactive to light, and a 3 millimeter bilateral. And we are also assessing patient's spine and other possibility parts of injury. We lot rolling these patients. However, we not found any obvious deformity, contusion, abrasion wound, punctured wound, burn scar, laceration wound, swelling of the back of the body. However, we're not doing anal tone at these patients due to these patients at scene, not in hospital. And we also performing the secondary survey, as I mentioned previously on my case clerking, and also we doing the performing top to toe examinations, the full sample history and top to toe examinations are found in my case clerking. And I'm also administer IV tranexamic acid 1 gram stat in 10 minutes towards the patient in view of tachycardia and suspecting these patients having massive bleeding and lead to the hypovolemic. We're doing the monitoring, such as the vital sign monitoring. We noted the tachycardia ranging is 110 to 115 per minute upon observation. The GCS charting baseline GCS is 14/15, E4V5M6. E3V5M6. There is no GCS drop upon observations in the ambulance, and also we're giving fluid, giving 2.1 normal saline due to tachycardia. And we also put these patients with oxygen therapy upon arrival, patient receiving high flow mass 50 liters per minute. And also we doing the vital sign monitored every minutes. We inform the medical desk towards patient's conditions, estimate time of arrival by using the mnemonic to missed. And as I mentioned previously, this patient 16 years old, male male, LHMVA motorbike skidded, sustained multiple abrasion wound over body today. And these patients motorbike skidded during went back to home from school, tried to avoid the car from front. Patient not wearing helmet and fall at left side of road. Patient sustained deformities and open wound 3 cm times 2 cm over left distal upper limbs, throughout upper radius ulnar fracture and deformity of a left femur region, throughout left femur close fracture. Patient having tachycardia with low blood pressure and delayed CRT. We suspect patient having hypovolemic and multiple abrasion wound over facial region. And we given these patients 50 liters per minute high flow mask, 2 large bore intravenous cannula inserted, 2 pints of warm normal saline started, 1 gram of tranexamic acid given in upper limb and splinting applied, and also head stretches, splint applied. Patient is taken to red zone and time about 50 minutes from. So identifications of clinical diagnosis and interventions of this patient. So patients, LHMVA motorbike skid and sustained hypovolemic shock. In view of tachycardia 110 per minute, CRT delayed and minimal skin stenosis, according to ATLS guidelines, this patient is having at least class 2 of shock. Management of class 2 of shock includes inserting 2 large bore brand new intravenous cannula and run 2 pint warm normal saline. ATLS guideline also suggests for adding 1 gram IV tranexamic acid run in 10 minutes for the patient suspecting hypovolemic due to trauma event. And I'm also suspecting these patients have radius and ulnar fracture. The deformity of left distal end of upper limb suggests for the left radius ulnar fracture. Patient also having laceration wound 3 cm times 2 cm of deformity region. So this is suggests distal and left radius ulnar open fracture. In view of active bleeding, responded to hemorrhage control in these patients, direct compressions applied and bandaging. Upper limb splint applied to reduce movement and control bleeding and for the injury. So I'm also suspecting this patient having closed mid-shaft femur fracture. The deformity of a 2/3 left femur region suggests for closed mid-shaft femur fracture. No open wound seen. Tenderness of a left femur fracture and swelling. Head traction splint applied to this patient to track the femur to reduce pain and also to control the bleeding. We also suspecting this patient having abrasion wound over facial region. Multiple abrasion wounds inspected over patient facial region. However, there is no active bleeding, no obvious deformity seen during examinations. And I'm also suspecting this patient having retrograde amnesia in view of patient unable to recall exact event, most probably due to not wearing helmet and hit any possible blunt surface. Patient's conditions update to base and suggest for observations, possibility of head injury is high. In conclusions, the most important thing in pre-hospital care is communications. Therefore, assistant medical officer, as the one who responding any PHC cases, need to be good in using any device or any communication device, such as the government integrated radio network or GERN, to deliver the information about the patients and management that they give to the respective patients. The assistant medical officer also needs to be good in managing patients. To do so, they have to updating their knowledge about the latest update, especially in managing patients. For example, the update of basic life support and also trauma life support, and also they have to involving in any courses that will make them good for the better delivery towards patients from the scene to the hospital. Ladies and gentlemen, thank you to lend your ears to be with me in these case study presentations and hope to see you again soon. Thank you so much. Bye.